Hello everyone, welcome back to my channel. Today we are discussing about a topic called aplastic anemia. Aplastic anemia is a condition wherein there is bone marrow failure. The bone marrow fails to produce all the three lineages of the hematopoietic system, which is the red blood cell, the WBC cells, and the platelets. The causes of aplastic anemia is firstly idiopathic. Second most common is autoimmune. The third is that secondary to triggers such as infections, most likely viral infection, tuberculosis, a parvovirus, and the others could be secondary to chemotherapy, radiotherapy triggers, and exposure to certain chemicals like benzene. In case of aplastic anemia, the pancytopenia picture, wherein the counts of all the three lineages are reduced, and also you should have hypocellularity of the bone matrix. So when you think about pancytopenia, there could be different reasons why a patient can be pancytopenic. Firstly, if you have any deficiency of nutrition, which is mainly the folic acid and B12 deficiency. Secondly, if there is any disorder of the bone marrow itself, which is bone marrow failure, primary failure, which is the topic we're discussing, aplastic anemia. The other reason could be the bone marrow is being infiltrated with, say, malignant cells, either due to primary malignancy or malignancy which has been metastasized into bone marrows. The other could be bone marrow suppression, which is due to radiotherapy or chemotherapy or any other medication that we're giving. The bone marrow is suppressed, and that's why it is leading to pancytopenia picture. Other reason is infection, which infection is primarily affecting the bone marrow, especially in case of parvovirus, also in case of tuberculosis. So these are different reasons or conditions where you can have pancytopenia picture. But in aplastic anemia, in addition to pancytopenia, there is also hypocellularity of the bone marrow. So how do we see that? So for this, you need to have a bone marrow biopsy to look at the structure of the bone marrow and look for the matrix. So there are two procedures, which is bone marrow aspirate and bone marrow biopsy. So in bone marrow aspirate, you take the fluid part of the bone marrow, so you aspirate with a syringe, and that's where what you obtain are the cells, and you can check for the quantity of cells, the quality of cells, the cytology. That is bone marrow aspirate. But in case of bone marrow biopsy, you're taking a chunk of bone marrow and examining it. So you're looking for the matrix, and the architecture of the bone marrow. So this is especially useful in case of conditions like aplastic anemia, also myelofibrosis, also to see if the bone marrow has been metastasized with some malignant disorder. In these conditions, you have to look at the infrastructure. In most of the cases, they do bone marrow aspirate and biopsy back to back as a combined procedure. Once you have the confirmation or objective evidence of hypocellularity along with pancytopenia picture, then this is a clear diagnosis of aplastic anemia. What are the symptoms? So because all the three lineages are involved, because of the low red cells, you have anemia picture and symptoms of anemia. Then because of low WBC count, you have high risk of infections, and particularly infections which we'll talk about. Then because of low platelets, you have bleeding and bruising. Coming to the treatment of aplastic anemia, because the problem is at the stem cell level and it is at the early progenitor hemopoietic stem cells, and it's all the three lineages, the ideal treatment or the curative treatment is to do a bone marrow transplant. So this is ideally done in patients who are less than 50 years of age, and there are certain prerequisites before bone marrow transplant. And the actual steps include: first is to find a donor for bone marrow transplant. This is based on the HLA phenotyping. So HLA stands for human leukocytic antigen. The most ideal donor for stem cell transplant of hematopoietic system is the siblings, because they have 25% fully matched HLA compatibility. And if this is not the case, then you should find someone who is not related but is HLA compatible. Second is to prepare the recipient for transplanting. That is, they would be given certain chemotherapy drugs or agents to destroy the already active bone marrow. In spite of aplastic anemia, there are certain active cells still within the bone marrow. But when you're transplanting, when you're grafting, you want the bone marrow to be empty so that the graft itself can embed into the bone marrow and take over. So for this, you need to destroy the stem cells and destroy the early cells within the bone marrow. So they are given these agents. Based on why we are doing the transplant, it can vary from myeloablative. Myeloablative is high intensity therapy wherein all of the cells are suppressed and lost. This is done in case we are doing a stem cell transplant for malignant reasons like leukemia, because they are high active turnover cells and you want to suppress them or destroy them. In case of aplastic anemia, it doesn't need myeloablative because the cells are not very active. There are very few cells and they are tired and they're exhausted. So you just give a tiny dose to kind of suppress these cells. Then is to take the donor graft as such. So this is done by one of two procedures. One is take a bone marrow biopsy, like the posterior iliac crest, and do the bone marrow biopsy as we did for diagnostic purposes, and take the chunk, and then from this chunk of bone marrow you would separate the stem cells. The other is an invasive procedure. The other procedure is a non-invasive procedure, which is called peripheral blood stem cell collection. So actually you find your stem cells in the bone marrow. In this procedure, we give the donor a colony stimulating factor, and this colony stimulating factor releases the stem cells from the bone marrow into the bloodstream. And we take the peripheral blood as a peripheral stab, and then we take the sample, we process it, and then you you isolate the stem cells from it. So this stem cell has a CD34 plus, which is CD stands for cluster of differentiation. So which is present at the cell surface, and that is this is the marker used to identify the stem cells while we are processing the sample. Next is to transfer the stem cells as such, which is the actual transplant or grafting. This is done via peripheral stab, like as if we give blood products, they get the stem cells. So this was quite interesting bit for me because any transplant or grafting use, when you think about it, is quite it looks like a big procedure. But in case of hematopoietic stem cell transplant, it is quite simple. You give it peripherally, and then once the stem cells have gone into the recipient, they find their home. That is called homing, where they find the bone marrow. They're settled down there and they are engraft, which is the graft is taken up by the bone marrow, and they settle down and replicate and do their function. So that's the main interesting bit. The next is to see how is the graft doing as such, like the prognosis and to monitor the graft. This is done by checking blood counts, which is red blood cell count, WBC count, platelet count. You can see if they're improving on the upward trend. The other bit is also symptomatic improvement for the patient. If there is, you need to have certain objective evidence. Your cell count could be an objective evidence. If there are concerns, so especially in all the cell counts, your neutrophil count is the first one to show a difference. For this, you can expect anything less than a month to around a month and a half that you have to see your neutrophil count raising. If your neutrophil count raises, let's say, it's a good prognosis, it's a good outcome. If it does not, then you would start to have your doubts about the graft itself. So then you can do something called chimeric study, which is again very interesting. So in chimeric studies, chimera actually stands for hybrid. So in this case, because there are two different genetic material in the same patient, it is chimera, and the chimeric studies itself studies about which DNA genetic structure is the patient itself and how much of this is the donor. So this is based on concept called genetic fingerprinting, wherein STRs, short tandem repeats, which are repetitive strands of a combination of nucleotide material, is what is unique to a particular person. For transplant, They check the genetic coding, or they check the STRs of this particular recipient, and they check the STRs of donor, and that's done as a genetic fingerprinting, and that's left for further reference. And then once the transplant is done, they can take the blood of the recipient after the grafting is done, and they check the genetic composition of the blood products itself. They can categorize patients into one, if it's 100% donor genetic material within the hemopoietic system, then it's a good outcome, because the graft has embedded well and it is growing and multiplying, and the graft has taken over by the patient. Second is, if it's 100% the genetic material is from the recipient itself. That means we've grafted the stem cells, but they're not taken up. They're either lost or destroyed by the host. The other thing is the 50% of genetic material is by the host itself, which is the recipient, and 50% from the graft, which is there's still a bit of uncertainty whether this would lead to failure or success, and we just have to give a bit of time. And we could also give this particular candidate some more immunosuppressants so that their immunity is suppressed and the graft can take over. This was quite interesting how we can monitor and see in case a patient is not ideal for bone marrow transplant. That is, if their age is more than 50 years and if you don't find a HLA matched donor yet. Then the next strategy would be to go for immunosuppressive therapy. It's called IST. So in immunosuppressive therapy, two components are used, which is ATG, which is anti-thymocyte globulin, and cyclosporin is used. So these are agents which suppress the immunity, and because this whole concept of IST is based on autoimmunity. So even the idiopathic component of aplastic anemia has an underlying autoimmune component to it. So in that sense, immunosuppressive therapy is the next mode of treatment if bone marrow transplant is not suggested. So also in certain patients, they also give L-thrombopag these days. L-thrombopag is a thrombopoietin agonist, a chemical agent which kind of boosts the bone marrow function. So it boosts all the three lineages, not just one of the lineages. So it boosts red cell production, platelet production, and WBC production. So it is used in combination with ATG and cyclosporin. The downside of IST, immunosuppressive therapy, is that it has 30% relapses, and it's not a curative treatment. It is just, as we said, suppresses the immunity and kind of give the body time to take over and settle. But the patient is never free from aplastic anemia because that component is always there. And the success rate is also not great in IST. Some of the patients have good response to IST, and the severity of aplastic anemia might be reduced. Like in the case of moderate or severe, they become mild case of aplastic anemia. But if there is a relapse of immunosuppressive therapy, then we have one of two options. One is to try immunosuppressive therapy again, because if it's just a relapse, because we expect 30% of relapses to happen anyways, we could try IST if they had good response to IST initially. If they did not have good response to IST and there is a relapse, there's no point in trying IST again. Then we could go for bone marrow transplant and start looking for donors. But the advantages of IST is that there is no graft involved. So there is no graft rejection. There's no graft versus host disease. So graft rejection is wherein the host, the recipient, rejects the graft given. So my immunity is destroying the graft which I was given. So that is graft rejection. To prevent this, even before transplanting the graft, I would be given immunosuppressants to suppress my immunity to prevent this form of reaction happening. The other is graft versus host disease, wherein the graft which is transplanted has immune cells and it is overwhelmed, and that graft starts to fight against my immunity and is destroying my body. So that is graft versus host disease. Both these conditions can be possible in bone marrow transplant, but in terms of immunosuppressive therapy, we do not have these problems. If there is a failure after bone marrow transplant for any reasons, as we discussed, maybe graft rejection or graft versus host disease, or there is poor sampling, which is when they're only donated a small sample of stem cells, which was not taken over by the body well, that is, it was not engraft properly, or the HLA typing was not done properly. For any of the reasons, it can lead to graft rejection or graft failure, which is a broader term. So let's talk about graft failure then. So in case of graft failure, we could again go for bone marrow transplant for the second time, or do something called DLI, which is donor lymphocyte infusion. So DLI is usually done in patients who have hematological malignancy like leukemia. But in case of aplastic anemia, DLI does not work because it's the stem cell which is a problem and not just the lymphocytes. The next topic we want to talk about is a prophylactic antimicrobials given. In case of aplastic anemia, the concern for infection arises from low neutrophil count. So in neutropenia, patients are more susceptible for gram-negative infections, bacterial, viral infection, fungal infection, and PCP infection, which is polycystic pneumonia. So in case of antibacterial, we give them ciprofloxacin or levofloxacin for gram-negative cover. In case of antiviral, we could give them acyclovir, valcyclovir. This is to cover for herpes infections like herpes simplex virus or herpes zoster, varicella zoster virus. Then in case of fungals, we can give them posaconazole, fluconazole. This is to cover candida and aspergillus. Then for PCP, we give them cotrimoxazole. So cotrimoxazole also has the antibacterial cover, but it's more in terms of PCP cover. And cotrimoxazole have trimethoprim and sulfamethoxazole combination to it. Prophylactic antimicrobials are started when the neutrophil count is low, as we discussed, and especially when it hits the target of 0.5. That's when we start the prophylactic.